So how do you write a prescription? So just to refresh your memory, as an independent prescriber, you can only prescribe the drugs you're legally allowed to. So, for example, certain controlled drugs you're not allowed to, substance abuse you're not allowed to, as an independent prescriber, if you're not a doctor who's been under specialist training to prescribe for substance abuse. Dispensers can only dispense drugs that they're legally allowed to, that have been legally prescribed. And again, as we've said before in the first lecture, the NHS BSA will only refund pharmacies for those ones that are legally prescribed as well. So challenges and opportunities as a new prescriber. So think about your area of practice. Think about some of the things that we talked about obtaining prescriptions, storage of prescriptions, for example, preventing fraud. Maybe you're the first prescriber in your area. Think about some of the challenges ahead. You may be the first prescriber in your team. How do those in your team feel about you now being a prescriber, either independent or supplementary? Is there some jealousy? Is it going to work well as a team? Are they going to all be asking you to see the patients that they know need prescribing for? Think about the future, the reality of when you're a prescriber. What's it actually going to be like for you in your area of practice? What patients will you be prescribing for? What drugs will you be prescribing? The practicalities of getting the information onto the shared record and so on. How, if you're faced with a dilemma, for example, someone asks you to sign a repeat prescription, how are you going to handle that dilemma? For those from allied health professions or pharmacists, what are your individual challenges or difficulties that you can envisage in your area of practice in terms of maybe not having access to the shared record, for example, having access to an independent prescriber if you're prescribing in a supplementary capacity? If you're asked to prescribe, say for an independent pharmacist, if you're asked to prescribe outside your specialist area, how you manage those challenges from clients. Patients see you with a prescription pad. They don't know that there's certain caveats to that you can prescribe for certain conditions but not for others and so on. They find it a bit difficult to understand in a lot of cases. I know myself when I was first an independent prescriber, I was working as a health visitor and I'd be in a clinic, a big open clinic where you'd be seeing lots of ladies with their new babies and offering advice, prescribing, etc. And it was people saw out the corner of their eye, your prescription pad, and they made a beeline for you and started to say, oh, can you prescribe me this? Can you prescribe me that? And at first you may feel flattered by the attention. You may think, oh yes, I've got this new skill, but you've got to be very, very careful. Again, remembering the accountability and saying to people, no, I can't prescribe for you, or I can't prescribe that drug, or there was no indication. And it's quite hard. So think about how you're going to manage those challenges as well, and pressures on you to prescribe. In 2007, Chadwick et al. Undertook an audit of the North West Strategic Health Authority, and they looked at diabetic foot team, and particularly within there was an independent nurse prescriber, tissue viability nurse, and there was a supplementary prescriber who was a podiatrist working in this team, and they had some fantastic results in terms of how they reduced hospital admissions and the need for amputation. So incredible results for patients, incredible results for costs, incredible example of interprofessional working with two different disciplines working together in conjunction. And hopefully in a not too distant future, we've had a recent consultation for podiatrists and physiotherapists to be moved from supplementary to independent status, and let's hope those days aren't too far away, because there's so much more scope as we're moving and evolving in prescribing, non-medical prescribing, for the benefit of our patients. So prescribing, as I've mentioned in the first lecture, is not just an opportunity for providing a seamless service for patients where they just have to see you, they're assessed, diagnosed, plan is made of care, treatment options are considered and discussed, and then their treatment is applied, as in a prescription and other management issues are given to the patient. So it's a one-stop shop for them, so it's fantastic. But what else is an opportunity for when you're prescribing? What else can be there? So medication review, we've said before, every opportunity where either you're meeting with a patient or discussing drugs in any shape or form, it should be an opportunity for a medication review. It's very easy to say, oh, I'm very busy, I haven't got the time. But it shouldn't be something that happens on an annual basis just with the doctor. Anybody has the knowledge about drugs and interactions, contraindications, polypharmacy and so forth should be actively undertaking medication reviews and making sure that the patients are being protected, given the best service for their own well-being. It's an opportunity to review a care plan when you go along, maybe to just monitor, or you've been asked to go and someone needs a repeat prescription. Make sure that you fully review and an assessment's undertaken, that you're not just going on someone else's assessment. They may not have been as efficient as you in terms of asking the right questions or excluding certain things or being critical in terms of their thinking, in terms of differential diagnosis. They may not have asked those mantra questions which I suggested, as in allergy history, what other drugs they're taking. When you review them, whether it's medication review or review of the care plan, they may have gone along and bought something else from the pharmacist, a complementary drug, which may be completely skewing the normal efficacy of a long prescribed drug. And suddenly no one can understand what's happening. I heard of a case recently, one of my anticoagulant nurse specialists had a man who used to be well controlled with anticoagulant therapy, warfarin, his INRs were stable. Suddenly they were all out of kilter, couldn't get them under control. They were trying desperately with changing drugs, and eventually someone asked the key question about other medications, and it was reviewed in terms of the complementary therapies this man was taking, and they managed to identify a particular product that's completely skewing his INRs, and when this was taken out of the equation, they resorted to completely control back to as they were before. So never underestimate the impact of over-the-counter, particularly complementary and herbal remedies as well. It might be an opportunity for you to say, I can't manage this anymore, it's outside my area of competence, or I think I know what's going on here, but it's not in my competence, I need to refer on. You shouldn't assume because you can prescribe that the patient doesn't need to see anybody else. Part of your role is to still refer on, if necessary, to someone who is more competent or specialised. It's a fantastic opportunity to review compliance. The figures on compliance are horrific. 50% non-compliance with some medications across the UK. So it's a real issue. I'm sure, think about yourselves. Have a discussion amongst yourselves in groups. Think about, have you ever not complied with a regime prescribed for you? I'll be very surprised if there's one of you in the room that can say they haven't. We all do it. We think sometimes we know best. We think we know when to stop a medication. We think, well, we just miss out one because we think, this one doesn't work so well if I take it this time of day, and so on and so forth. And other people are doing the same. And sometimes you hear some hair-raising stories about compliance issues or changing regimes on no evidence at all. People getting confused. I was told last week of a friend whose parents have both got quite severe health problems. Her dad went into hospital with chest pain, which turned out to be sort of gastritis from quite a bad UTI and distress this had caused. And when she got him back home, she found that his wife, who was confused following a stroke, had put all the tablets out on the worktop, both the couple's tablets, and merged them together like a pick and mix. And the wife had also taken it upon herself a few days before to stop the husband's diuretic, which one of the predisposing factors for his UTI. So people change regimes, people don't understand, people get confused, people experiment and do all sorts of things. And I'm sure if you have a discussion amongst yourselves, you can share many, many stories like I've just imparted to you. So compliance is massive. It can be to do with so many other factors. Think about what is important for compliance in terms of palatability, formulation, regimes, misdiagnosis, patients not being listened to at consultation, and it goes on the list. Have a discussion between yourselves in terms of those sorts of scenarios that you may have met in practice yourselves. Think about how other health professionals may have been instrumental in causing that non-compliance as well, and what you can do to overcome that in the future. And reflect on your opportunities as a prescriber with this new advanced role of how you can enhance patients' well-being. So now let's get down to writing prescriptions. You're supposed to write prescriptions in accordance with what it says in the BNF, as we've already covered in part 1. If you are, as a prescriber, you should be writing prescriptions in accordance with your preparation on your professional program as well.